GI motility. So GI motility means it is the movement of GI tract. Movement of GI tract by involuntary smooth muscles. It is by involuntary smooth muscles. In these smooth muscles, gap junction are present. So it is a unitary smooth muscle. As gap junctions are present, it contracts as a unit. So it is called a unitary smooth muscle. Now the pacemaker. So what is the pacemaker of GI tract? The pacemaker of GI tract is Kajal cells, interstitial cells of Kajal. Interstitial cells of Kajal. Where it is present? It is present in stomach, at mid body region of stomach, along greater curvature. This is the position of interstitial cells of Kajal. It will give a restless membrane potential. Now what is the restless membrane potential? Look, -60, -40. So it oscillates like this. This is a restless membrane potential. This restless membrane potential, it is not action potential. This is the threshold potential. So only after crossing the threshold potential it becomes action potential. So when it crosses the threshold, it will have a depolarization and a repolarization. Now basic electrical rhythm. Basic electrical rhythm. It is this oscillatory restless membrane potential which oscillate between -60 millivolt to -40 millivolt. It does not produce action potential. This basic electrical potential does not produce action potential, no action potential. So no muscle contraction. This action potential has two phases. That means if the threshold is crossed, there is action potential. This action potential is having two phases. One is depolarization and one is repolarization. Depolarization is due to calcium influx. Repolarization is due to potassium efflux. Now, the basic electrical rhythm, it is highest in duodenum, greater than ileum. Duodenum it is 12 per minute. In ileum it is 8 per minute. It is lowest in cecum. It is only 2 per minute. Okay. Now speaking about deglutation. So deglutation means it is the process of swallowing the food in the mouth. There is three phases. oral phase, pharyngeal phase, and esophageal phase. This is considered as voluntary, whereas these pharyngeal and esophageal phases are considered as involuntary. Now, deglutation reflex. The sensory nerve fibers, cranial nerve 5, 9, 10. These are afferent. That means these are the sensory innervations. It goes to central medulla, where it passes along nucleus of Tectus solitarius. The motor component, that means efferent motor component, come from cranial nerve 5, 7 means facial nerve, and hypoglossal nerve. This is a motor component, efferent component. And these motor fibers are innervating muscles of pharynx, tongue. These are concerned with swallowing. Now coming on to esophageal motility. So, when food is present in the esophagus, it activates peristalsis. So, there will be a peristaltic movement. There are 3 types: primary, secondary, tertiary. Primary peristaltic contraction, it is the normal physiological, and it is progressive. It progresses. This is initiated immediately after swallowing. Now, secondary peristaltic contraction, it is also progressive. It is due to irritation. When esophagus becomes irritated, secondary peristaltic movement begins. Tertiary esophageal sphincter, esophageal contraction, it is non-progressive, and this will lead to esophageal spasm. Okay, so primary and secondary peristaltic contraction both are progressive, whereas tertiary is non-progressive. Now coming on to the peristalsis. Now it's the stimulus. So when the food reaches the esophagus gets stretched. When the esophagus gets stretched, it releases serotonin. And this serotonin will activate meninteric plexus. So the stimulus is the food reaching the esophagus. It stretches the esophagus, serotonin released, and it leads to the activation of meninteric plexus. It will be like this. This is a food bolus. In the proximal part, it will be constricted, whereas in the distal part, it will be dilated. That means segment before the food undergo contraction. So it is called retrograde contraction. It is by acetylcholine and substance P. The segment after the food bolus, it undergo relaxation. This is called anterograde relaxation. anterograde relaxation. Nitric oxide. So which substances which initiate anterograde relaxation is nitric oxide and VIP, vasoactive intestinal peptide. Okay. Now what is achalasia cardia? Achalasia cardia. So when nitric oxide is absent, there will be no relaxation. So there is unopposed action of acetylcholine. That means acetylcholine concentration increases. So there will be sustained contraction. Sustained contraction in lower esophageal sphincter. So there will be sustained contraction in lower esophageal sphincter, and this leads to a motility disorder, achalasia cardia. So what is its treatment? Treatment means the botulinum toxin. Botulinum toxin can inhibit the acetylcholine, so it is used in treatment. So achalasia cardia, nitric oxide is absent, so there will be sustained contraction in lower esophageal sphincter, so treatment by botulinum toxin. Next comes gastric motility. Gastric motility. Till now we were discussing about the esophageal motility. Coming on to the gastric motility. The food now reaches the stomach and there will be relaxation. Proximal stomach undergo relaxation, and now food can be stored. This is called, now food can be stored. So this is called receptive relaxation or gastric accommodation. The second phase is retropulsion. Retropulsion is the backward movement of the food when it reaches the pylorus sphincter, because the food will reach the pylorus sphincter and bounce back. That movement is called retropulsion. It helps in mixing and grinding of food. The third phase is gastric emptying. Okay. Now, what is gastric emptying and what are the factors? Gastric emptying. Gastric emptying means the food which is present in the stomach is emptied to the small intestine, mainly the duodenum. The control point is pylorus sphincter. Which are the factors which increase gastric emptying? One is increase in stomach volume is a stimulatory factor. Because when the food in the stomach increases, it leads to increase in volume and it will promote gastric emptying. Gastrin hormone is a factor which also increase the gastric emptying. Now, which are the factors which decreases gastric emptying? CCK. It is a factor which decreases gastric emptying. Nervous system, sympathetic nervous system and parasympathetic nervous system, they are having a least role in gastric emptying. Now there is a reflex which is called Enterogastric Reflex. Entero means small intestine, gastric to stomach reflex. This is under the control of enteric nervous system. It is stimulated by unabsorbed carbohydrate, protein, fat in duodenum. Stimulated by unabsorbed carbohydrate, protein, fat which is present in duodenum, and this will create a hyperosmolarity. This is a stimulating factor for enterogastric reflex, which decreases gastric emptying. Now coming on to small intestinal motility. Small intestinal motility. So when food reaches the small intestine, there will be peristalsis. Apart from that, there is when this is considering this as food, the food reaching in the small intestine will be like the proximal part and the distal part will both be in the contracted state. This is called segmentation. The part of the small intestine before and after the food particle contract. Both ends are contracted. This is done to retard the movement of food. So by retarding the movement of food, it will get adequate time for digestion and absorption of food. Next, coming on to large intestinal motility. So we can divide into proximal and distal colon. In the proximal colon, absorption of water, electrolyte takes place. This is the most efficient site for water absorption. In the distal end, it stores fecus. It is for storing fecus. Now movement pattern in large intestine. When food reaches the large intestine, hostrations. The movement is called hostrations. So what is hostrations? In the large intestinal wall, both circular and longitudinal muscles are present. Their combined contraction is called hostrations. It helps in absorption of water and electrolyte. It predominantly takes place in proximal colon. Proximal colon is a place. The second movement is mass movement. It involves a larger area of colon. That means the substance moves from one segment of colon to next segment and finally to rectum. And rectum get distended with fecus. This will activate defecation reflex. Now what is this defecation reflex? It is controlled by two sphincters, internal anal sphincter and external anal sphincter. Internal anal sphincter is involuntary smooth muscle. External anal sphincter is voluntary skeletal muscle. It is supplied by pudendal nerve. It is having both sympathetic and parasympathetic component. This parasympathetic facilitate defecation, whereas sympathetic inhibits defecation. Now coming on to the pathway. Distension of, so when the fecus gets filled, it leads to distension of rectum. So the sensory fibers, afferent fibers, it reaches to, through the afferent fibers, it reaches to the sacral segment. The center is present in the sacral region. So the parasympathetic nervous system activated. It results in relaxation of internal anal sphincter. Then subsequently relaxation of external anal sphincter. When the time relaxation of external anal sphincter occurs when the time and place is convenient. This will result in defecation. Now, two notes are there. When the rectal pressure is 18 millimeter of mercury, rectal pressure. When rectal pressure 18 millimeter of mercury, there will be first urge for defecation. When it is 55 millimeter of mercury, it results in soily or defecation. That means it relaxation of both external and internal sphincters. Now, what is gastrocolic reflex? Mainly seen in infants. Gastrocolic reflex seen in infants. So when food reaches the stomach, colon get activated. Food in stomach. When food is in stomach, the colon gets activated and defecation occurs. This reflex is called gastrocolic reflex. This is the reason why infants defecate immediately after food. It is coordinated by gastrin. This is controlled by gastrin. Now coming on to migratory motor complex, MMC, migratory motor complex. This migratory motor complex, it is a motility pattern during fasting state. It has 3 phases. This is a phase 1 where there is no activity. This is phase 1 where no activity, so called quiescent period. This is called phase 2, which is having irregular activity. This is third phase, which is having regular activity, burst of regular activity. This contraction originate in stomach and migrate to colon at the rate of 5 centimeter per minute. Okay, 5 centimeter per minute. Now what are its functions? It cleans the GIT. Clean GIT. That means there will be bacteria, foreign bodies, undigested idle food particles. So this will be moving from stomach to the colon. It also prepare GIT for the next meal. It happens every 90 minutes. It is regulated by a hormone called motilin. It is a timekeeper hormone. So thanks.